دكتور، هذا البارت الثاني مال السيمينار مال Mandible Fracture ويا زميلتي آمنة منهل راح استهل. The management of the mandibular fracture depending on the classification of the mandibular fracture. There can be various surgical management to open reduction internal fixation with this case in the picture and closed reduction. Let's talk about closed reduction. Restoration and alignment of the fracture fragment to their original anatomical position without visualization of the fracture line. Fracture reduction that involve technique of not opening the skin or mucosa covering the fracture site. Fracture site heals by secondary bone healing. This is also a form of non-rigid fixation. Closed reduction. Indication of the closed reduction is component of non-displaced favorable fracture, a grossly comminuted fracture, fracture exposed with significant loss of overlying soft tissue, eventual mandibular fracture in children, coronoid process fracture, and condyle fracture. The contraindication of this technique involve unfavorable fracture at the angle of the mandible and unfavorable fracture at the symphysis or body of the mandible. Medically comprised patient. This is the advantage of this technique include inexpensive, only stainless steel wires needed, usually arch wire also, easy availability and convenient, short time, stable, gives occlusion semi to adjust itself, and conserved, generally easy, no greater operator skill needed, no foreign object or material left in the body, no operating room needed in most cases. Cellulose formation allows bridging of small bony gaps. Disadvantages include cannot appoint absolute stability, contributing to uneven function, no complaints from patient due to long period of IMF, difficult nutrition, and complete oral hygiene impossible, possible TMG joint scoliosis, denervation of muscles, alteration in fiber types, myofibrosis and atrophy and stiffness, change in TMG cartilage, and weight loss, irreversible loss of bite force, and decreased range of motion of mandible, risk of went to operator manipulating wires. The methods of immobilization: bonded orthodontic brackets by bonding a number of modified orthodontic bracket onto the tooth and applying light wires or intermaxillary elastic band, what you see in the picture. Interdental wiring. This method is only applicable when the patient has a complete or almost complete numbers of suitably shaped teeth, what we see here in the picture. Arch bears. Arch bears are indicated where the patient has an insufficient number of suitably shaped teeth or when a direct link across the fracture is required. IMF screw. These screws are self-drilling and self-tapping. The screw head is elongated and contains holes for wire placement. They are inserted through small incision in the labial vestibule, avoiding injury to the apex of the nerve teeth. And cap splants. They are fabricated by making an impression of the fractured jaw and preparation of the cast on which a gap sibling made of acrylic or metal can be fabricated and used for fixation of the fracture. External pin fixation. This method is seldom used nowadays and is indicated in special conditions such as infected fracture, fracture caused by gunshot injury, or pathological fracture. Open reduction, internal fixation, the second management we use in mandibular fracture, implies the opening of skin or mucosa to visualize the fracture and reduction of the fracture. Can be used for manipulation of fracture only, can be used for the non-rigid and rigid fixation of the fracture. Indication of this technique use: variable and unstable mandibular fracture, fracture of an individual mandible, fracture with severe displacement, delayed treatment with interposition of set tissue that prevents closed reduction technique to approximating the fragmentation. Methods of internal fixation: interosseous or transosseous wiring. It is the direct skeletal fixation of two or more bone fragments with the idea of wire ligaturage pulled through previously drilled hole. Mini blades, which mean these are the most common form of internal fixation used in the management of mandibular fracture. They provide seam, rigid or load-sharing fixation. Three-dimensional titanium mini blade. They are based on the principle of the quadrangle as a geometrical stable configuration for support. The blades are adapted to the bone and are secured with monocortical self-cutting screw. Non-compression rigid blade, reconstruction blade. These blades provide rigid or load-bearing fixation. They are mainly used in the management of infected, severely comminuted fracture, and fracture where there are continued defect, and in a fracture in which delayed union or non-union has occurred. They are required bicortical screw and are fixed in place at or near the lower border of the mandible in order to avoid damage to the inferior alveolar nerve and the dental roots. Compression plates. These plates provide rich fixation. The principle of compression plating is by transforming the downward force of screw insertion into a compressive force. Lock screw. An oblique fracture compression lock screw can be applied without a blade. They are placed perpendicularly across the fracture line in order to avoid displacing the fragment. This technique appears to be ideal for parasymphysival and symphysival fracture, but it becomes technically more difficult in body or angular fracture because the risk of damage to the inferior alveolar nerve increase. Complication. Early complication include misplaced fixation, infection in the fracture site, nerve damage, late complication, malunion, delayed union, and non-union, and sequestration of bone. And this is reference, and thank you for listening.